three pillars, one of them being optimizing the vaccination programs. Number two, introducing the HPV molecular test in our screening strategies. And number three, of course, as my colleague said, educational projects and international efforts are, of course, non-negotiables. So I'm going to start with the optimizing of the vaccination programs. As you can see, the region itself introduced the vaccination kind of late. We're talking about in a heterogeneous way as well. Countries like Mexico and Panama has the vaccine since 2008, but other countries like El Salvador or Costa Rica, from where I'm from, introduced it only in 2019 and 2020. That has given us some upper hand though, and in terms of changes that we have quickly introduced, we've been able to take a further step and introduce changes in the vaccination strategies that have already been proven to accelerate the goal of the 90%. Changes like what? Like 1 or 2 doses rather than 3. The gender-neutral strategy that has already been more than proven that accelerates getting into the goal. The catch-up schedules, not only for children under 10 years old, but also older children that have not been able or in contact with the HPV still, and we have an opportunity to get them protected. And of course, high-risk populations that we already know that they are under the influence of a higher burden of disease related to HPV. So we did another observational analysis, and we conducted a study among healthcare professionals that are part of our committee. We did it in 19 Latin American countries, of which 17 had implemented the vaccination programs by 2025. The years were 2024 and 2025. And the inquiry was about the target population, the vaccine type, the doses that were recommended, coverage percentage, strategy of immunization, and the cost of US dollars. Some of the results, my colleague is gonna show them later on, but I wanted to summarize one of them really quick. And one is that 47% kept an upper age limit of 15 years old in their schedules. Only Mexico and Costa Rica had the non-valent vaccine, and all other countries had the quadrivalent vaccine in their schedules. I know that there are others changing into that, but that's where we should be moving forward. 58% had a gender-neutral strategy. The lowest first dose uptake was reported by Guatemala, which was 26%, and the highest one was Ecuador and Chile with 98 and 94% respectively. 47% included a one-dose strategy, and only 5 countries included high-risk populations in their strategies, which were Brazil, Colombia, Uruguay, Panama, and Mexico. So moving on to the second strategy, HPV as a screening test. This is data published in 2022, which is a global report. And what they found is that cytology is still the most used screening test in the world with 78% of usage. But when we see HPV tests in the second strategy, only 35% of countries recommended in their official administrative recommendations. Latin America is probably not overdone threshold, but that's what's more important, or probably more interesting about this report is this estimation they did. So they took all the countries that were under the 70% coverage threshold, and they estimated what was the incremental factor they had to do, the extra effort those countries had to do in order to achieve that goal. And as you can see, it was between 20 and 70% augmentation of the screening tests that we should be doing in those countries. Those 6 that you can see in the screen are the ones from Latin America, but there are a lot of other countries in the world. And let's just have in mind that screening test is just not having the test or applying the test. It has to do with the follow-up. It has to do with appropriate diagnosis. And of course, it has to do with appropriate management of the lesions. And to be finishing up, some educational projects and international efforts our committee has undertaken. One of them is the consensus of quality standards for colposcopy and colposcopy training from the Latin American Federation. I'm more than proud to say that 2 authors are sitting with me in the main table of this article, and it's important because colposcopy in our region has a lot of issues as well. that disseminated in the training, in terms of training, it's very individual depending, and obviously it's a cost to get proper training. So it's very heterogeneous, and obviously it has to do with the precise diagnosis and management, as I already said. We performed a certification last year on vulvar pathology, and of course we couldn't leave out the diseases related to the vulva, which we were all included in those certifications, and we had over 200 participants that year. We've also done webinars around cervical cancer prevention and about the strategies we should be using. Those were directed to both colleagues, and in another webinar it was really in relation with myths associated with the virus, the human papillomavirus vaccine, and that one was directed for patients. And we have over hundreds of patients throughout the region online with us, talking and bringing down those myths that at the end of the day are barriers into the vaccination strategy. We also did a reinforcement colposcopy course that was held in both Guatemala and Costa Rica, and we were planning on repeating that next year throughout the region. And as you can see, we had dozens of residents. We can't lose out the residents in our programs. Those are the ones who are going to do better things than we are doing. And just to finish, some of our videos, because we've done also some social media information capsules, and they're all in our Facebook and in our Instagram, talking about myths around the vaccine. Those obviously are directed to patients as well. And another one talking about cervical cancer and all the awareness we should be doing basically every day of our days.
Thank you so much.